Okay, good morning everyone. We are doing viral and bugs that go together. So this one has a very broad ulcer. And so look at the bit of the ulcer. First off, sheets of plasma cells, EOs, and let's see if there is anything else. There we go. So, could be ulcerative zoster. The sheets of plasma cells were a clue that this was a penile ulcer in someone immunosuppressed. And then you have this giant cell with peripheral margination and molding. Get ourselves there so everyone can see it. So, multinucleation, molding, and margination of chromatin, so chronic ulcerative herpes, and if you see chronic ulcerative herpes with a thread-like rolled border, your patient is always immunosuppressed. There's cancer, there's lymphoma, there's HIV, there's something there. Accounting for it. Very good.
Would you check for syphilis on that patient regardless of this?
Especially, people often don't have just a single venereal disease, so you would probably check for everything. So, has a little bit EDV-like blue cytoplasm, and this is a cyst. A cyst with round parakeratosis and hypergranulosis. So a proliferative verrucous cyst, and many of these, especially if they have EDV type HPV in them, go on to cystic squamous cell carcinoma. So verrucous cyst can remain benign or can go on to cystic squam.
There's nice broad reticular degeneration, so I'm thinking viral.
So thinking viral, and is there only reticular or also ballooning?
There's also ballooning, which could be a pox virus, but that looks like margination molding, so herpes virus.
Yeah, exactly. So the little bit of a red herring to start, because reticular degeneration, you normally think of pox or enterovirus. There's also ballooning degeneration, and then there's clear-cut margination of chromatin and ballooning, which lead to herpetic. And clinically, it was zoster. But the reticular degeneration would suggest viral, but not necessarily herpes virus.
It looks like we've got some light pale bluish cells. Definitely wart-like, I think, EDV.
Yeah, so your stratum corneum is that coarse basket weave typical for verruca plana, and then you have the foamy blue cells typical of epidermal dysplasia versiformis, and you already see belonoid atypia. So what is the lifetime risk of cancer in these patients?
Almost 100%.
Almost 100%. In fact, they usually die in their 20s or 30s if they don't have sun protection like you would do for a patient with xeroderma pigmentosum. So, early intervention, very important.
Looks kind of warty.
Kind of warty. And this was taken from the Netherlands. So from down there as a seborrheic keratosis. What do you think?
I think it's condyloma. I'm trying to see if there's like atypia maybe right there in the middle.
Yeah, so you're looking, one, to see is there pulmonary papulosis type of atypia. Also, the horn is not that of a seb. It's not a lamellar horn. So condyloma have compact horn. They have coarse hypergranulosis. They have scattered coilocytes. The horn and round parakeratosis help distinguish it from anything else in the genital area and are fairly predictive of how it's going to hybridize with in situ hybridization for papillomavirus.
Blister.
Probably artifactual. The
What's
way
my
it is.
remedial word?
So it's myrmecia. So first off, you're on palmoplantar skin. Myrmecia means anthill because clinically it resembles a deep burrowing lesion. And then you see the red, coarse red chunks which characterize HPV type 1, which when it is a deep palmoplantar wart is myrmecia.
Areas of acantholysis, but it's some organism. It seems to be organisms or giant cells.
Tell me about the nuclei within the giant cells.
Yeah, they're herpetic looking, molding.
So there's multinucleation, molding, and margination of chromatin, peripheral basophilic eggshell of chromatin, so that's herpetic. This is an isolated little vesicle right in the hair follicle. So probably,
There's a zoster.
yeah. And given the isolated vesicle and the lack of associated vasculitis,
That'll be varicella.
chickenpox,
Chickenpox.
yeah, varicella, chickenpox. Whereas zoster, they tend to be grouped, and they tend to have a rip-roaring leukocytoclastic vasculitis with them. Varicella doesn't have that. And apparently in Latin it's varicella, but if you say that, no one knows what you're talking about.
So there's a large blister. It looks like acantholysis. Looking for herpetic nuclear changes.
Yeah, and you may not see them because all the cells are necrotic, but you see ballooning degeneration, which suggests a herpetic blister. And then what's in the underlying dermis?
LCV.
LCV, so this is probably zoster. And this would be a typical picture for zoster. So in varicella, you're likely to see the intact nuclei with the molding. In zoster, very commonly, you just have eosinophilic necrosis, but you can still make out there was ballooning degeneration leading to the blister and underlying leukocytoclastic vasculitis, that combination typical for zoster. The other things typical for zoster, anytime you see necrosis of a hair follicle, isolated necrosis of hair follicle, or isolated necrosis of sebaceous gland, think zoster. So necrotic sebaceous gland, necrotic follicle, think zoster.
Dr. Elsa, would there be anything else on the differential without the classic chiroplastic nuclear changes?
Not really.
Okay, good.
Yeah, I mean, you have enough there. You have ballooning degeneration, underlying LCV. You got enough for zoster there.
So we have acanthosis, and then a little hypergranulosis, but not much.
Little hypergranulosis,
Yeah,
shape of the parakeratosis,
pretty round.
round.
So, like a viral.
Yeah, viral like herpes.
Like wart.
Yeah, like wart, HPV. And if this is genital, and you're already getting a little bit of disorder, epithelial disorder, this is one where you would follow the patient for the possibility of Bowen's. We need to brighten this up a little bit. That's a little better. Okay. If you do hybridization, in situ hybridization, in low risk HPV, it's only in the coilocytes, and it's a single chromogenic. Often you use a blue chromogen, so blue blob that sits out in the cytoplasm. Whereas in high risk HPV, it is a dot-like intranuclear pattern. So it's very characteristic, the pattern when you do in situ. And it's that incorporation into the genome that makes the high risk high risk.
Alright, lots of inflammation.
Lots of inflammation. What's all of this stuff?
Blood.
Yeah, here the granulation tissue, all those vessels, edema, inflammation. So we got granulation tissue, we have elongation of the rete. Let's see if we got anything else that might help us. So we look at the epidermis, and a lot of the epidermis is necrotic. And then in addition, it's a little hard because you have necrotic nuclei, but what we're looking for are eosinophilic inclusions in the cytoplasm. So if you have granulation tissue, elongation of the rete, and eosinophilic cytoplasmic inclusions, like right there, and you think of what kind of viral thing?
Like a pox, like we're
Yeah, like parapox ORF group, which is exactly what that is. So granulation tissue, elongation of the rete, and then cytoplasmic eosinophilic inclusion. True pox tend to have both nuclear and cytoplasmic. Parapox, you often just see cytoplasmic.
is it a worm?
So you got sort of a cyst here, right? And what's causing this cyst?
Verrucocyst.
What are those kind of bluish things?
DV.
That would be in the cytoplasm down here. This is actually, the kind of slide that would perform well, because it's all, do you recognize these structures? Anyone, what are they? Yeah, Henderson-Patterson bodies of molluscum. So you don't have the scalloped, it's not an obvious molluscum, it's a sneaky molluscum, right? So uncommon variants of common things. It's just recognizing the Henderson-Patterson bodies. Of sneaky molluscum.
Degeneration of the epidermis.
So there's degeneration of the epidermis. And is it more reticular or more ballooning?
Ballooning.
Ballooning degeneration, and then any nuclear changes that help you?
Yeah, it's herpes.
Yeah, You have multinucleation, margination, that peripheral eggshell of chromatin. You also have lots of neutrophils here. So more likely simplex, varicella, or zoster. With all the neutrophils or vasculitis, takes you to the zoster side. The other thing to remember is if you have something that looks almost like keratoacanthoma involving follicle, and you have herpetic change, your patient has HIV. That's verruca zoster, and it is almost exclusively described in patients with HIV, and it's often the presenting manifestation. So, something important to keep in mind.
Yeah, thin shave.
Thin shave.
There's some EDV-like change.
And there's some EDV-like change, that blue cytoplasm and the coarse basket weave. So epidermal dysplasia versiformis, that can be hereditary, autosomal recessive, or it can be acquired, and again, usually as a sign of HIV.
Cystic structure.
Well, that's the question. So first off, what are all of these cells with the little crenated truncan nuclei and the big vacuole around them? Coilocytes giving rise to round parakeratosis. So it looks like it's caused by HPV. And then does this HPV thing, so was it content to remain a condyloma? See these blunt pushing things bulldozing their way into the tissue? This is verrucous carcinoma. So verrucous carcinoma arising in HPV. So that's your biopsy specimen. Do you have a diagnosis? So what are those chunks? Anybody? Molluscum. So those are Henderson-Patterson bodies again. Right. So you have a little piece of tissue, and it's just a matter, do you recognize it? Inflammation, necrosis, and that's an erector pili, implies that's the follicle. It's all necrotic. You are correct, that's zoster. So eosinophilic necrosis of follicular unit, whether sebaceous gland or follicle, think zoster. And that way you won't miss it.
It's just fingers unless there's smearmation. There is smearmation.
Yeah. So pink chunks, endophytic wart, acral skin, Ramesia.
We've got some acantholysis in the epidermis.
Acantholysis, are they normal size cells?
No, it looks like there's multinucleated giant cells,
And-
ballooning
And
degeneration.
ballooning degeneration, and what's down below?
LCV, so zoster.
So probably zoster. Ballooning degeneration zoster, and in zoster you usually cannot make out the cytopathic effect very well. So, which is why you often get just the ballooning degeneration in eosinophilic necrosis or eosinophilic necrosis of the follicular sebaceous unit. That one wasn't fair. We're going to move on. Let's see.
So looks like blooming degeneration.
More ballooning or more reticular or a combination of both?
Maybe a combo.
Combo. So
Yeah.
now you got to think. So which viruses normally give you ballooning? Herpes. Herpes group. Which ones normally give you reticular?
Or like pox or
Pox, parapox, enterovirus. So you're going to look very carefully for herpetic type viropathic effect. And if you don't see it, you can always look at the clinical. These were oval blisters on the fingers, toes, and backside.
hand, foot, and mouth.
Hand, foot, and mouth. And then with the A6 variety, people get sicker and they look almost like eczema herpeticum. So it's referred to sometimes as eczema coxsackium because you're going to think eczema herpeticum in terms of the groupings.
A lot of inflammation.
Inflammation. Some necrosis.
I don't see any giant cells. Looks like zoster again.
So let's look, and you have degeneration here, and you can make out all these pink blobs in the cytoplasm.
Oh, or
Yeah, so more likely parapox with the inclusions, the eosinophilic inclusions. There's a real pretty one right there. So ORF.
So we have HPV-like changes with the hyperkeratosis, hypergranulosis,
Yeah.
and choleleucocytic changes.
Basket weave, hyperkeratosis, hypergranulosis, coilocytes, and this is kind of broad and flat. What might you call a flat wart?
Flat wart.
A flat wart. Yeah, so verruca plana.
Lots of inflammation in the dermis.
Lots of inflammation in the dermis.
Mostly lymphocytic.
I heard it.
Scabies.
So you see the little popped ova in the corneum, and even though we are doing virus today, don't forget scabies. The things you will miss in your career. Tinea scabies, they will make fools of you many times.
There's a lot of inflammation in the dermis,
Inflammation in the dermis,
and then a lot of scaly crust.
big crusted lesion, elongation of the rete, kind of irregular pseudoepitheliomatous hyperplasia.
Looks like an ulcer right there. I
Yeah.
think that's,
Ulcer granulation tissue.
is it more for like parapox?
Well, I'd certainly wonder about that, and I'm looking for eosinophilic cytoplasmic inclusions, which are not popping out at me, but the history was ORF. So, often after the county fair, or someone who works with farm animals, or has gone to a petting zoo, and in the animal, it's scabby mouth. So it's crusting around the mouth is what you get. That's what it's called in sheep, is scabby mouth.
So it's like there's acanthosis and kind of some like dermal edema.
Acanthosis and dermal edema.
It's a little ulcerated.
Yeah.
And there's a molluscum.
And then there are Henderson-Patterson bodies.
What collision?
Yes, so you have the coarse basket weave. Looks like someone has taken a little 2mm punch and punched holes in a compact corneum.
Flower.
Do you see any coilocytes? Just a few here, right? So coilocytes should have a little crenated, raisin-like shriveled nucleus and a white space around it. On cervix, they're very strict with that definition for pap smears. In skin, you often get large gray nuclei rather than the shriveled little. So over here, all of these large gray nuclei, those are also coilocytes. Right. So these large gray would be what we get often in skin. So you can have the black shriveled pycnotic nucleus, or you can have the large gray nucleus. Either one counts as a coilocyte in skin, unlike cervix.
EDV?
So, would be a thought. I mean, you certainly have some spongiosis, you have some crust, some serum, dermal edema. The history is these are juicy red papules in a kid clustered at about elbows, knees, dorsum of the hand, cheeks. Giannotti Crosti. Very good. And it's the sort of thing where the histopath doesn't really help you until you pair it with the clinical, and then you've got your diagnosis.
It's like a little Sebi wart or condyloma.
Okay, so is it Sebi wart or condyloma?
Chapter's probably condyloma.
Certainly not. It doesn't have the basket weave corneum or the loose lamellar corneum of a Seb, and so in this chapter, probably condyloma. In the United States, given the prevalence of condyloma, pretty safe bet.
Crusty.
Yeah, kind of crust. You got lots of staphylococcal colonies, so an ulcer, crust, and then we're going to look in the granulation tissue beneath the ulcer.
You're looking for a bug.
Well, we're looking for something. Let's see if we can find it nicely here. Not as nice as I'd like. We'll have other examples of it. Imagine, if you will, in the vessels, huge endothelium cell, kind of owl's eye nucleus and ample cytoplasm, CMV change, which doesn't cause the ulcer but reactivates in the ulcer base and gives you a chance to treat them before they go blind. We've covered that pretty well. Let's jump to potpourri here. Grab a box at random, bottom shelf. That's the one. I'll pass them out. You guys don't mind. Come on, back in. Perfect. Okay, fasten your seatbelts, everyone.
There's no worms today?
Oh, no worms. Look at the worms, review them, they're fun, but worms are, other than recognizing that it's a worm, I mean, in practice, you're gonna send it to a derm path person, or you're gonna look in a book to see which
So on
one
our
it is.
test, they're not going to expect us to know the
I
difference.
cannot discuss content of test. However, what only to say what's been publicly disclosed, which is that the content of the test roughly reflects the content of the practice. What percent of your practice is worms? Yeah, so they're kind of fun things, whereas on hospital consults you see fungal sepsis all the time, right? And people live or die based on whether you can identify the organism. So, in terms of relevance to clinical practice, worms would be down there, but they're fun. I mean, and you do see them, and then they're very exciting. Okay. Shall we? Where did we leave off? So, epithelial tumor doesn't palisade at all, has little vessels with this osteoid-like stroma around the vessels. Anyone want to jump in? Yeah, poroma or porocarcinoma, and given the infiltrative growth here, we're a little worried about porocarcinoma. So this, so characteristic, we call it poromostroma. Right, it looks almost like osteoid, but with little vessels in the middle, and it's a million wraps of basement membrane zone material. As a group, the acrospiromas have ample cytoplasm, never palisade. So epithelial tumor, ample cytoplasm, never palisade, poromostroma, and then you look for hypercellularity or infiltrative growth for malignancy. That one was called malignant hidradenoma, acrospiroma, poroma, all the same thing. We're never happy with one name for things. This thing was a bump shaved off, and what's in the bump? Smooth muscle, and it kind of looks like a pinwheel at the periphery, little pointy thing. So leiomyoma, and these were grouped in a plaque because there was loss of heterozygosity, probably for what syndrome? Reed syndrome with fumarate hydratase deficiency and renal carcinoma. So important to recognize.
High nuclear cytoplasmic spindle body could be spindle cell melanoma.
Yeah, which is exactly what it was. So it's spindle cell, something nasty, and then your next step is immunohistochemistry. And that used to be a lymph node.
So we've got a thin shave, got some hyperkeratosis. Can't really tell if that's just like papillary dermal edema.
Yeah.
Seems like it.
Epidermis normal or not normal?
It's very thin and like a
Yeah.
faced.
So an atrophicus epidermis
Yeah.
with hyperkeratosis and papillodermal edema, kind of smudged collagen.
Yeah. I don't really see a lymphocytic band, but I'm thinking of LS.
Okay, what do you think about this vessel?
It's pretty dilated.
Any other thing you want to entertain?
Radiation.
This is radiation dermatitis. Looks LS-like, but with the lack of a lymphoid band. Kind of hard to tell in a superficial shave, but then things that help you, the dilated vessels, radiation fibroblasts when present, radiation elastosis in the fibrous tracts of the hair follicle, lack of adnexal structures, all could help establish a diagnosis of radiation dermatitis.
So almost like clear cells.
Almost like clear cells.
Some
Sometimes that can be like renal cell.
Yeah, it could be renal, the way they're kind of back to back with some pigment. It could be melanoma, it could be clear cell, so-called clear cell sarcoma, malignant melanoma of soft parts. It has a 1222 translocation, so something nasty, and it looks like it turned out to be clear cell sarcoma.
Sebaceous hyperplasia.
Yeah, sebaceous hyperplasia or folliculosebaceous cystic hamartoma or trichodiscoma with all the stromal elements, which could go with what kind of syndrome. So if this is someone who had started young with dropping lungs, with atelectasis and pneumothorax, spontaneous pneumothorax, Birt-Hogg-Dubé. And then you have to watch for what in them. Renal oncocytomas.
So we have acanthosis, pH live.
Anastomosing pink strands, blue buds. What would be your anastomosing pink strands, blue buds tumor? Anyone? Pincus. Hyperepithelioma of pincus.
What is it? Acrospiroma.
Yeah, acrospiroma, poroma, hydradenoma. Take your pick. They're all the same. It's sweaty. You have sweat ducts. It never palisades. It has visible pink cytoplasm.
There's perikeratosis. And neutrophils, I think. They're
Yeah.
kind of alternating. So like
Newts on top of para, on top of newts, on top of para, on top of newts, on top of para.
psoriasis.
Psoriasis. Very good.
This looks like a spitz.
Looks like a Spitz. So
Or pigmented spindles. Maybe it's a root.
yeah. So whether or not you regard that as a subtype of Spitz. Spitz would have larger spindle and epithelioid cells. Pigmented spindle cell nevus tends to be proximal extremities, usually young women, usually eruptive, quite dark. Small spindle cells and unique mutations. But it does look spitzy.
Looks like a wart.
So you have a little cleft, and you have these round bodies.
Warty.
Yeah, so that's a corond, which just is French for round body, and then these are grains, and you have clefting and villi, so you have acantholytic dyskeratosis, which depending on the clinical could be Dariers, could be warty dyskeratoma, could be Grover's, could be vulvar curl, acantholytic dyskeratosis, any of those things.
Proven.
Are you sticking with that story?
Probably.
Yes, this is the chirpies. So multinucleation, molding, margination of chromatin, that's a herpetic. Mustard.
There's some inflammatory cells. Lymphocytic infiltrate at the DJ.
Yep. And where else is the infiltrate?
Kind of a poorly looking adnexal structure there.
And the infiltrate, if you had to characterize that infiltrate, is it lymphoid or neutrophilic?
That looks neutrophilic there.
Kind of crushed, but I'd say they're lymphoid. And crushed lymphoid sometimes is a clue to lymphoma, so you'd have to consider that. But do you think that infiltrate is round or vertically oriented, like a column?
No, vertically oriented.
Which could be a clue to
Lupus.
lupus. So this, I think, lupus or lymphoma, and I'd want to work it up from there.
It's big and red. Giant cells. Ooh. Is that keratin?
Yeah, so
Like
this
in
is
cysts?
a ruptured EIC. Someone recently completely ruined crab rangoon for me, describing it as fried EIC.
Oh.
Which really kind of, next time you eat it. Keloid. You see the whorls of hypertrophic scar and then the red keloid collagen. Bubblegum. Yep. Verruciform xanthoma. So I also heard someone say porokeratosis. They're the V's are a little like cornoid lamella, but there are no disc keratotic cells at the base, and instead they're neutrophils. So all those red V's, wart on fire, screaming, the V's are screaming that it is a verruciform xanthoma. It's not fair.
Monomorphic infiltrate. I can't tell if they're like
So first off, where do you think you are?
probably mucosal.
Is that
face. It's muscle.
so it's striated muscle, so somewhere head and neck,
Yeah.
right? And then a fairly monomorphous lymphoid infiltrate. Endothelial cells really prominent. And then what's with this kind of damaged bluish hued vessel in the middle of the whole thing? What would give you a lymphoid infiltrate with, yeah, ALHE, that's exactly what it is at scan, is you have that bluish hued larger vessel in the center and then the lymphoid aggregates. Big clue to interlymphoid hyperplasia with eosinophilia. Well done.
Got a bunch of biopsy.
What are all these circles?
Fat.
Fat up in the dermis? Or could it be xylocaine from the injection?
Definitely could be that.
And if it's xylocaine from the injection, what does it tell you about the condition? It was sclerotic, right? You had to pump the xylocaine in there because it was sclerotic. So when you see those round circles, it tells you this was something sclerotic. And then we're down in the fat.
Doesn't look very happy.
Fat does not look happy. And you have this frost on a window pane type change.
Maybe like lipodermatous.
Maybe like lipodermato. And this is kind of a young, early fat necrosis. So stasis fat necrosis is lipodermatosclerosis.
It's a little like dermal proliferation. It almost, parts of it look like Paisley tie. So I guess if it's a little thing, it could be a syringoma.
Given that it's a little BB, sclerotic stroma, tadpole-like ducts, syringoma. Very good.
Is that like a hibernoma?
Like a hibernoma, brown fat, central round, non-scalloped nuclei. Well done. See the wheels turning.
So we have a look like some elastic proliferation. We have a pigmentation nests and
Kind of patchy, perivascular, periadnexal. Splayed between collagen bundles. So that kind of patchy pattern. You know, congenital nevus. Yeah. Congenital pattern nevus.
Increased sebaceous gland. Would just be sebaceous hyperplasia. It's a DF.
It's a dermatofibroma with sebaceous induction overlying.
So this looks like a papule. Maybe wart on fire.
Maybe wart on fire, vericiform xanthoma with all those red leaves. Very good.
This is a Shane Cook kind of box.
This is a Shane Cook kind of box. This is the Shane Cook Memorial Session.
That's hilarious.
Oh, it makes it sound like he's dead.
Yeah,
Which is not good. We don't want that.
Some of the horn looks like Sebi. Oh. Are those vertical?
They are vertical.
And they're, I'm trying to think if it's either Erythrosin or Canada.
So, does that help you at all?
Canada?
Yeah. Newton horn, spongiform, you see vertical, and they're too thick, too wide to be erythrasma. So, sometimes you can see that they're hollow or that they're also yeast or buds, and that can help. Okay.
Acrospiroma.
So, this palisades, which acrosporoma would never. Pink strands, blue buds. Yeah, pincus tumor. Very good. And pincus tumor will always have ducts in it as well, which is why you were thinking acrosporoma. Let's see.
Fish or epithelioma.
Yeah, so epithelioma or adenoma, depending on the proportion. And so you'd look for Muratori syndrome in the family.
maybe that kind of pink strands,
Pink strands with prominent ducts. Fibroepithelium of pincus if they have buds. This is kind of a verrucous looking thing. Not sure if it's stasis or tumor all over the lower extremities. And anywhere you biopsy, it shows these snaking ducts. Anyone? Syringofibroadenoma. Syringofibroadenomatosis, sometimes it's called, when it's in the setting of stasis. So mascaro tumor.
So this one, a little bit of sclerosis and collagen, some small bees around the adnexa. I worry about lupus or connective tissue or something.
Yeah. Lupus, lymphoma, lichen striatus, Lewy. The sclerosis often goes with lupus. The fact that you're seeing vertical and transverse in one punch suggests this was an alopecia. You can see some interface dermatitis. So, lupus. Very good. We'll do one last one. Be careful, it's tricky. Tricky lymphoma. You see the purple palisade and the clear cells. And with that, we're done.
Thank you.